It's a pleasure to be here and to be able to talk about a topic which I think today is considered not very controversial, but certainly 20 or 25 years ago, when my colleagues Mark Williams and John Teasdale and I started to do this work, it was controversial. Meditation was something which had a lot of baggage associated with it, and the use of meditation in psychiatric or mental health contexts was viewed with a lot of skepticism. And so one of the bigger stories here, I think, is how is it that a case could be made to justify the use of mindfulness meditation, and what does mindfulness meditation actually bring to people who are coping with a depressive or an anxiety disorder? How can it help them? And I think also a very important question is, what does the research literature show about how effective these practices can be? Those are the three main points that I'd like to address in my talk. And so let me first of all start by just reviewing some of the background of what we know about depression and anxiety disorders. In the late 1960s, there were a number of epidemiological studies which showed that people who became depressed or had an anxiety disorder, if you follow them for 10 to 15 years, what you find is that a large number of them, the majority actually, will have a second and third and fourth episode of depression. And so depression and the view of depression changed from being seen as a single episode illness to an illness that is potentially recurrent and potentially chronic. And what was important in these kinds of epidemiological data is the estimate that each new episode or each additional episode of depression carries with it an approximately 16% risk of a subsequent episode. And so if someone has had 4 episodes of depression, then they would have a 64% chance at having a 5th episode, which is quite high. And so what that did was it led to the need for treatments to be developed that addressed the person when they were depressed, but also when they were not depressed, so that we could try to prevent relapse and this increased risk of new episodes entering people's lives. And so what you see here is a breakdown of the approach to treating depression. When someone is healthy, they start to develop symptoms, and their symptoms lead to a reduction in functioning. Typical symptoms include inability to sleep, inability to concentrate, lack of interest in food or appetite, maybe feeling exhausted or fatigued all of the time, sad mood, easily crying, easily feeling overwhelmed. When treatment is initiated, people start to regain their functioning. And so once symptoms are severe enough, people seek help. Could be an antidepressant, it could be psychotherapy. Then they start to show an improvement, and sometimes, very often, they come back to the same place that they started. They're back at work. They're socializing with friends. They're able to continue with their everyday activities. And so this is called a period of remission. The symptoms have gone away, but there's still a very high risk of relapse when people are in remission. And so that's an important time for people to still receive some kind of treatment. If people maintain their remission, then they are considered to enter a period of recovery. But as we said, recovery still has a risk that another episode of depression will develop. And so mindfulness meditation and its use in mood disorders is really reserved for this particular segment of the trajectory of the illness. It's really for people who have had some treatment, they no longer have intense symptoms, but they are still at risk for relapse or still at risk for recurrence. So what do we know about how relapse and recurrence are dealt with more traditionally? And here we have some evidence from studies which show that if people receive cognitive therapy, they can reduce their risk of relapse significantly. This is one of the first studies in 1992 that looked at people who were treated for their depression with either a medication, like an antidepressant, or cognitive therapy. And what it shows here is that people who continue to take their antidepressants, let's say for a year after they were no longer depressed, they had a relapse rate of 32. People who received cognitive therapy, they had a relapse rate of 21. People who received the drugs and cognitive therapy for a year afterwards, they had a relapse rate of 15. And none of these numbers are actually significantly different. But all of these numbers, 15, 21, and 32, are significantly different from the people who had a relapse rate of 50%. These are people who were treated with an antidepressant, and then the antidepressant was discontinued, and they were sort of left on their own. Even though they were feeling better, they had a very high rate of relapse. So cognitive therapy does a good job of preventing relapse. So does continuing people on antidepressant medication. Maybe that's all that's needed. Why do we need to introduce mindfulness meditation? What, in addition, does that get us? Well, to understand that question, I think we need to understand how does cognitive therapy prevent relapse? And one of the ways that it prevents relapse is that people begin to write about their experiences with negative thinking. That's a big thing in cognitive therapy. If you're in cognitive therapy, you're going to be writing about your negative thoughts. Not just when you're with your therapist, you're going to be writing about them in the week between when you see your therapist. You might see your therapist on a Tuesday, and you have some negative thoughts that start to bother you or trouble you on a Thursday. You're going to write them down on this piece of paper called a thought record, and you're going to bring them back to your next therapy session, or you might do therapy on yourself by filling out these different columns on the thought record. So cognitive therapy helps people prevent relapse by teaching them skills to work with and to examine their thinking styles, to see whether the way that they're thinking about situations or the way that they're thinking about themselves is supported by their experiences. And so you can see here, there's a situation I got, for example, my boss was upset with a project that I did at work. And then the next thing you're asked to do is to write about what emotion you felt. And maybe you felt disappointed, or maybe you felt fearful, or maybe you felt angry. And then what thoughts were going through your head? What did you think about yourself that the boss yelled at you? Maybe you thought you were inadequate. Maybe you were worried that you were going to get fired. And so you make your way down this list of columns all the time, paying attention to the thoughts that you're having, and is there evidence that supports this negative way of thinking about yourself, evidence that doesn't support it, and is there a way of coming up with a balanced viewpoint? So I guess a natural question, and we ran into this 25 years ago, is if cognitive therapy does such a good job preventing relapse, why not just continue with cognitive therapy? Why introduce mindfulness meditation? Don't you already have something that works and is effective? And so we felt that there was a good reason for introducing mindfulness meditation, which is that in order to do this kind of work with the thought record, you need to have thoughts that are very negative. You need to have thoughts where you're saying that you're a loser, or you're inadequate, or things never work out for you, or you're jealous of other people, or you need material for this. And what we found was that when people have recovered from depression, their thinking isn't always extreme and always negative. So these negative automatic thoughts are not as prominent when people have recovered. So there's less material, if you will, to work with and to use on these thought records. The other thing that we thought was very important is that people need to learn skills that can be practiced every day, not just when things are bad. Now, with mindfulness meditation, you can practice it every day. It doesn't have to be a good day, and it doesn't have to be a bad day. You can simply sit and help yourself with practicing mindfulness. With the thought record, you usually have to, in CBT anyways, in cognitive therapy, you usually have to have something bad happen to you, because then you can write about it, examine it, and evaluate it. The advantage of mindfulness is that you can practice it every day. And also, to just start teaching people cognitive therapy skills who may have been treated for the depression with an antidepressant and have never had therapy could be very difficult, because it would be very unfamiliar for them. And so with this reasoning, we felt that there was a good case to be made for introducing mindfulness meditation. And I received a small grant from the MacArthur Foundation in 1991 to develop a version of therapy that can prevent relapse, a psychological therapy. And these are my colleagues. That's John Teasdale. This is Mark Williams. And we'd heard of John Kabat-Zinn, who was doing work at that time with mindfulness meditation and chronic pain. And so we spent some time visiting him and watching him and people at the Center for Mindfulness teaching, and took elements of the work that he had done and integrated it into our own work, and developed mindfulness based cognitive therapy, which I'll talk about in a couple of minutes, what it is, an 8-week program. And evaluated it, and also emphasized in our book the importance of mindfulness meditation, and the instructors who would be leading mindfulness-based cognitive therapy classes themselves having a mindfulness practice, themselves practicing mindfulness. So if they were asking their patients to practice mindfulness, they knew what they were talking about because they were doing it themselves in their personal lives. We thought this was really important. But maybe it's important as well to take a step back and to describe what mindfulness is. It's a term that a lot of us use, and I think has many different meanings. And what I'd like to do is share with you how I introduce this to people in our groups, or people that I work with. Because mindfulness can sometimes be a little bit of a very big concept, I like to bring it down to earth. And so when I talk about mindfulness, I really talk a lot about attention. And so attention is something that we already know about. We already know how to pay attention. We already have the capacity to pay attention. But it's paying attention in a particular kind of way. So mindfulness is the awareness that comes to us when we pay attention on purpose, when we pay attention to our experience in the present moment, and when we do not judge what our experience in the present moment is. So it's a particular way of paying attention. On purpose, meaning I'm the one who's in control of my attention, and I'm going to, bring it back from wherever it might be to right here in the present moment. And whatever I find or whatever I notice, I'm not going to judge that. And that's a way of allowing people to feel like they can also practice mindfulness because they know what attention is. It's not a novel concept. It doesn't involve sitting in a particular posture or listening to bells or anything like that. It's about attention. And the other thing that it's about is training yourself so that, like any skill, with practice, you can start getting better at it. So these are two parts of the same definition. We already know how to pay attention, but to be mindful, we need to practice it almost like we're building a muscle. And some people have talked about this as building an attention muscle, building up an attention muscle so that we can use it to investigate our experience. That's something that Angie said at the beginning of the talk today was, you may have noticed your mind moving to places that were pleasant or moving to places that were unpleasant. This is the ability that mindfulness gives us to investigate our attention. And when we use mindfulness in the context of clinical work, dealing with mental health issues, what we're really talking about is using mindfulness to help us regulate emotions. The uses of mindfulness in spiritual contexts, in traditional sources that mindfulness was initially developed in, has many uses as a spiritual path, a path of awakening, path of liberation, a way of people feeling connected with their culture. But in a mental health context, I would say the more prominent goal is to practice mindfulness to help people regulate their emotions, especially their negative, difficult emotions. And this is because when we are able to pay attention to our experience, there are things that we are able to undo, ways of managing our emotions that might not be adaptive, that mindfulness can help us manage them in more adaptive ways. So for example, when we investigate our experience and that experience happens to be a sad mood or a fear that's overtaken us, a typical response might be to just avoid feeling that altogether. With mindfulness, we have an attitude of allowing emotions to stay in place and investigating them. Also, when we have a feeling, we might worry and ruminate about it. When will it go away? What does it say about me as a person? And we might end up feeding it so that it builds on itself and gets worse. With mindfulness, we're simply observing feelings that are present without having to problem solve them or make them go away. And the other thing about mindfulness is that we become a lot closer to seeing how we might be judging or criticizing ourselves. We might say that there's something wrong with us for being sad, or something wrong with us for worrying, or having ruminative thoughts. And once people become aware of how much they judge themselves, sometimes it's easier to let go just a little bit of that grip. So these are the three ways in which mindfulness can help with managing emotions. And there are a lot of different ways in which mindfulness is used in mindfulness-based cognitive therapy and in generally used in mindfulness meditation. And these ways all involve three different targets. The first target is that mindfulness allows you to get to know your mind and body together. So if you think of a practice like the body scan, you're paying attention to the whole body, going about investigating region by region. As you do that, you start to see patterns of experience. For example, you might notice that you're worrying a lot, or you might notice that you're feeling sad a lot. And then these emotions come back time and again, and you recognize them. Oh, there's sadness. Oh, there's worry. Or there may be ways in which you're able to connect certain states of mind to symptoms that you might be feeling. So, for example, remembering someone who insulted you and playing that over in your mind time and again, you might make a connection that that's leading you to feeling hopeless or leading you to feeling angry. And once those connections are made, you can see if that's something you want to continue to do. Now, how does that actually happen in mindfulness training? The first mindfulness practices that we start with are very concrete, very basic activities like eating or like feeling the body. And so with time, people start with being mindful of eating or being mindful of their bodies. And then with time, as the sessions and the weeks of the program proceed, people start to become comfortable with more subtle objects of attention, like the breath, or sounds, or thoughts, or even difficult emotional situations. So if you remember what I said about training a muscle, you'll see that we start with just paying attention to what it feels like to eat and what gets noticed, and then the body. And then eventually we move to sitting with sounds and thoughts, which are not so easy to find and not so easy to attend to. And one of the ways of seeing this in black and white, I think, is to notice that in mindfulness-based cognitive therapy, there are 8 sessions. Each session is about an hour and a half to 2 hours long. And you can see that the first 4 sessions are devoted to enhancing the ability of group members to pay attention. So noticing automatic pilot, noticing how we often live in our heads, noticing how our minds can be in 5 different places at once, noticing how when we have strong negative emotions, we tend to push them away. And so there's a lot of mindfulness training that goes on in the first 4 sessions of the program. And in the second half of the program, we start to become a little bit more focused on dealing with depression and other negative emotions in ways that involve mixing in or sprinkling in some cognitive therapy principles. So for example, session 6 is called Thoughts Are Not Facts. Session 7 is called How Can I Best Take Care of Myself? And session 8 is Maintaining and Extending New Learning. So the idea is that in sessions 1 to 4, we learn the basic principles of mindfulness. In sessions 5 to 8, we consolidate those skills so that they can become part of a routine that we can use once the program is over, because the program really is over after 8 weeks. And in order to help people, we've written a couple of books that are for the public to learn generally about the mindful way through depression. There's a workbook that people can use to take themselves through it. And there's also a manual for therapists who want to run mindfulness-based cognitive therapy groups. So I hope that that gives you a little bit of a background for how mindfulness can be introduced and can be relevant in dealing with depression and anxiety disorders. And now I think it's important for us to take a step back and look at the research evidence that evaluates how effective is this approach. So the first study that I want to talk to you about is a study that was done about 6 years ago, and patients here were depressed, and all of them were treated with an antidepressant to a point where they were no longer depressed. And then they were followed for 2 years. So they were all treated to being well, and then they were followed for 2 years. So you can see time here, 25 months. And on the y-axis is the number of people who survived over 2 years without suffering a relapse of their depression. Now, in the blue line, everyone in the blue line group continued to take the medication that got them well in the first place. So if you were taking sertraline and you had a good response, you were no longer depressed, you continued taking sertraline for 2 years. People in the red line, the group here, MBCT, TS, were people who were treated with an antidepressant, and then they gradually discontinued their antidepressant and received 8 weeks of mindfulness-based cognitive therapy. The same program that I just described to you. And what you see here is that there's no difference in the people who managed to stay well between those who stayed on an antidepressant and those who discontinued their antidepressant and received mindfulness-based cognitive therapy. And this is a really important finding for a couple of reasons. The first reason is that the sample size is fairly large, 424 patients in total. And so this is considered a very well-powered randomized control trial. The second is that the fact that there's no difference between these two treatments suggests that for people who are having a hard time with an antidepressant, mindfulness-based cognitive therapy can provide equal level of protection for them, even over 2 years. And this is very important information, because for some people, they can start taking an antidepressant, but once they feel better, they may want to come off the antidepressant, or they might have side effects that are difficult to bear. Or sometimes the antidepressants themselves run out of efficacy and they kind of stop working. So there is this population of people who maybe they've gotten better with an antidepressant, but it's not an option for them any longer. And so they now have, according to this study, the possibility of being equally protected by coming off the medication and having mindfulness-based cognitive therapy. The second study that it's important to talk about is also a study that's very similar. All the people in this study were treated with an antidepressant to the point that they were no longer depressed. And then they were randomized to one of 3 different groups. One group, which is the group with the solid line here, came off their antidepressant and received mindfulness based cognitive therapy. This group here with the dotted line continued to receive their antidepressant. So in some ways, these two groups here are identical to these two groups here. Treated to depression, treated to wellness and followed. One group stayed on their medication, another group came off and got MBCT. Same thing here. We followed them for 18 months, not 2 years. Came off their medication, got MBCT, came and stayed on their medication. There is a third group here, which is an important group. This group came off their medication, but they received a placebo. So they weren't sure whether they were on medication or on placebo. And you can see that they had the worst outcome compared to these other two groups. So here we replicate the finding of no difference between antidepressant and MBCT, but if you take away the antidepressant, people do really poorly. The rate of relapse here is about 21, 22%. The rate of relapse here is about 69%. It's almost, actually, it's more like 70, 78%. So it's important because it shows that people who have recovered from depression still need some kind of ongoing treatment to look after themselves, especially once therapy has ended. And then the last study to discuss is this one, which is a meta-analysis based on about 1,500 patients from 9 randomized trials conducted around the world. And what it shows is that when you put all of this data together, the advantage of a meta-analysis is that you're combining information from different studies, and it allows you to have a greater confidence in the finding of the average benefit for people in different groups. And so in this case, there are people who recovered from depression and did not receive mindfulness-based cognitive therapy, and there are people who recovered from depression and did receive mindfulness-based cognitive therapy. And across these 1,500 patients, there is a 31% reduction in the risk of relapse for those who received MBCT. So once again, this is another way of making the same case that mindfulness-based cognitive therapy provides people with significant protection compared to people who don't receive it and who also may have recovered from depression. And there's also some very interesting research on how mindfulness impacts on neural systems that support emotion regulation. So if you remember, one of the things that I said about mindfulness is that it's very helpful in dealing with mental health because it allows people to learn ways to regulate their emotions. And in this case, what I'd like to talk to you about is a study that we conducted where we had people in a PET scan machine, and we had them watch films on a screen that made them feel temporarily sad. So we had a way of making them feel sad, and then we could look at the way in which parts of the brain were active when people felt sad, and which parts of the brain were less active. And did mindfulness do anything to change that? So the first finding is that when anyone feels sad, there are strong areas of activation in the brain. Not surprisingly, there's a lot of activation in the prefrontal cortex here, which is like in the middle of the head towards the front. And because people were watching films, there's also activation here, which is more in the occipital lobe at the back, which is associated with vision. So in people who were not trained in mindfulness, what you find is that there's a lot of activation in the front of the brain here. But people who are trained in mindfulness, you have less activation in the front of the brain. And you have more activation in sensory regions. So what seems to be happening here is that the parts of the brain that are naturally activated when people feel sad are often the ones that are involved with rumination and treating the emotion of sadness as if it's a problem to be solved, and thinking about what it means to feel sad, what has to be done about it. In people that have been trained in mindfulness, which is this red bar here, there was less activation in prefrontal regions compared to control people who were not trained in mindfulness. And then in people that are trained in mindfulness, there was relatively more activation in a region of the brain called the insula compared to controls, people who were not trained in mindfulness. And what's really important here is that the insula is a center in the brain that coordinates sensory signals from the body. And so if you think about what mindfulness meditation is doing, it's reducing the experience of emotion, because remember, these are activations in the brain that are present when someone feels sad. So for people who are trained in mindfulness, the parts of the brain that were involved in thinking about sadness were reduced, and the parts of the brain that were involved with the sensations or the sensory representations of sadness were increased. So for people who were not trained, it was the opposite. You can see there was more thinking about sadness and less of a sensory experience of sadness. For people trained in mindfulness, there was more of a sensory experience of sadness, less thinking about sadness. So somehow the experience of sadness, the experience of the emotions from the sad films was slightly modified by people who had training in mindfulness. And why is this important? It's important because when you actually look at the level of activation of the insula, that's the part that people that had training in mindfulness were more connected to. The more that the insula was activated, the less depressed people were. The more activation of insula was associated with a lower depression score. And so if people aren't trained in mindfulness and they're feeling sad, but their first move is to start to think about sadness, to become very preoccupied and ruminate about sadness or try to solve it, treat it like a problem, then that leads to less activation in the insula. If people can inhibit that and allow the sensations of sadness or what it feels like in the body to be present, chances are they'll be less depressed. And so in some ways, what we can try to understand about mindfulness is that it involves the restoration or the recovery of sensations. And that's very important, because if we allow ourselves to recover sensations related to sadness or fear or anger or anxiety, we're doing everything that we talked about when it came to how mindfulness can be used in a clinical context. We are trying to train people to allow emotions to be present instead of avoiding them. We are training people to notice self-judgment and to be a little bit more compassionate with themselves. And we are also teaching people the difference between having an idea of an emotion as opposed to having an experience of emotion. All of these three ways of regulating feelings are novel and very important, but they're often not taught in the context of therapy. Mindfulness meditation allows you to learn how to do this, and also importantly, it allows you to do it for yourself, so that when the course of mindfulness-based cognitive therapy or the 8 weeks are over, you have skills and you have resources that allow you to take this into your own life and make it your own. That's what's really promising about this approach. It allows people to become more collaborative in their own wellness. And these programs typically allow people to be supported because they include, let's say, a CD with guided meditations, or they include handouts or worksheets that people can take and put into a folder and read and support themselves. These are some of the ways in which I think these programs continue to make real strides, and the evidence for them is very, very positive. I think a big challenge now is to persuade health systems, either a governmental level or private health insurance companies, to offer these programs as part of a more general population health approach. It's still difficult, I would say, if I'm being honest, to find a mindfulness-based cognitive therapist where people are. There are training programs here and there, but they are not that well known. But at the same time, there are lots of online resources where people can download mindfulness meditation for free. I know that the Oxford Center for Mindfulness has a page dedicated to downloads of mindfulness-based meditations, and there's also MBCT.com, where we talk about resources for people, all of these freely accessible. And so my hope is that in discussing this with you, you'll have some interesting questions to talk about, but also that in learning about it for yourselves, you may be curious enough to dip your toe in the water, to see for yourself what this is like, and hopefully that there will be something here that will be truly of help and truly of benefit. That's why we started this work, my colleagues and I, in the first place. And I hope that through your interest and curiosity that you will be able to carry it on. Thank you very much for your time.